I would like to invite Dr. Ashay Karpe for the expert comments, and then Dr. Rishabh will give the closing remarks. Ashay, sir.
Yeah, thank you everyone. As Dr. Kumar sir has initially suggested, focus meeting, sometimes addresses more of the issues, and we get to hear a lot of things. Definitely, to begin with, we had like session on small cell, and even when I've seen the presentation by Dr. Rajiv Kaushal, I think slowly we are moving again in the era. Right now, adenocarcinoma or even squamous cell carcinoma, you cannot treat it without mutation. And I think we are heading towards an era where we know that, we knowing the baseline mutation analysis, we can treat this subset. Definitely, they constitute 10 to 15% of the cases, like small cell. But definitely, when we are looking at it, to get these better results, definitely this panel discussion also has addressed. And it's at the end of the day, what I feel is, it's again, as Dr. Patil said, it's a multidisciplinary board meeting where, nuclear medicine person, the pathologist, everyone sits together. And I think that cross-track should happen to benefit all our patients. So definitely, there's a lot of things which are highlighted during these discussions. I think there was one question by Dr. Roshni Bhagwat Madam is when to use 20 milligram versus 30 milligram sandostatin. Anybody wants to take Akhil or anybody? When you use 20 milligram versus 30 milligram sandostatin? Akhil?
So we routinely use 30, but only part is the cost constraint, which makes it different. So it is usual practice to use 30. Do you agree, sir?
Yeah, so the thing is that basically the ideal dose, I mean, like whether you're using short acting or long acting, but when you're using a long acting depot, usually we start with 20 milligram and, based on the symptomatic control, it's a symptom control, but, you never exceed 30 milligram, because there are certain situations we use as high as 40 milligram, but there's your non-malignant condition in certain endocrine conditions we are using this, but in malignancy, maximum dose we use in LAR is 30 milligram every 4 weeks. So it is based on the titration of the symptoms and how the patient is tolerating. So I think we really had a wonderful discussion. But looking forward again tomorrow to have a meaningful discussion. Now for the closing remarks.